Okay, so welcome everybody to the April edition of the CMR Journal Club. And today it's a very special one for me, not only because it's a featured paper, but because it's presented by Rohan Dharmakumar. And Rohan and I know each other since I want to say 20 years.
Yes.
And it was a particularly productive time during my time in Calgary when Rohan helped me with what was scientifically closest to my heart, which was an oxygenation sensitive sequence. And it's still a sequence that we're using in this rapidly emerging field of oxygenation sensitive MR. And it was during his time at Northwestern. And but his interest in the T2 star world also unlocked huge other potential. Some work that I also in parallel has started with Andreas Kumar in Berlin on hemorrhagic transformation of myocardial infarction, which is a clinically totally underestimated and underappreciated phenomenon. So hemorrhagic infarcts occur more often than we think in about half of the cases. And we just last week we had a case where it was clear that the reperfusion was too late. There was a lot of hemorrhage with infarct expansion and damage. So this is one of the ways to see whether an intervention, especially late intervention, led to more damage or more or some salvage. So that's why I'm very excited to have Rohan here himself today, talking about the featured paper, but also about another one. So we'll have a little bit more time than usual. And the first one is detecting hemorrhagic myocardial infarction with 3 Tesla CMR. So Rohan, thank you very much for coming and talking to us today.
Great. Thank you, Matthias. 20 years is a long time, but it feels like it's gone really fast.
Yeah.
So, so thank you for the opportunity to present this work. It's performed by a number of people in my team. And so, excuse me. So I'm going to talk a little bit about hemorrhagic myocardial infarction at 3T. That's what this paper is about. And as Matthias said, indicated earlier, in 2010 or 2011, the first paper looking at T2 star based detection of hemorrhagic infarction emerged, and that came from Andreas Kumar and Matthias Friedrich. And so I've gotten interested in hemorrhagic myocardial infarction also seems like for the past 15, 16 years. And my work nowadays is very much heavily centered around hemorrhagic infarction. So this paper, excuse me, sorry, I apologize if there's any noise here because I'm in a lab here with -80-degree freezers and
Actually the audio is fine. Don't worry. It's all good.
Right. So when you look at hemorrhagic myocardial infarction, we can see this. We can diagnose hemorrhagic infarcts on the basis of T2 star from Andreas and Matthias's work and 1.5T. And then, a number of us have published papers using T2 star at 3T. Of course, it's more difficult to do because of a lot of the off-resonance complications and things like that. But we wanted to ask a few important questions. One is that when do we actually see hemorrhage, and how early can we see hemorrhage with T2 star cardiac MR? And the second question we asked is, there's a number of papers that have come out over the past, 10, 15 years or so that have implicated that, you can see hemorrhage with T1 and T2. But even more recently, even after this paper has come out, we had other papers coming out with susceptibility weighted imaging for looking at hemorrhage. And so this, I'm going to talk mainly about T1, T2, and T2 star for diagnosing hemorrhagic MI at 3T. Most of the work is done in large animal models using dogs. And histopathology and cardiac MR, of course, at 3T on a Siemens system. And then we also, based off of some of our findings, we then did some translational work in about 50 patients with ST elevation MI reperfused with primary PCI. So I want to just walk through a few of the key things. So we studied dogs. LADs were occluded for 3 hours, and then reperfused, and then we were studying them immediately after reperfusion. So we would image with T1, T2, and T2 star 1 hour after revascularization or reperfusion in dogs. And then we would bring these animals and then image them, at 24 hours. And as the earliest time point after, they come off anesthesia, and then we'd image them at 3 days, 5 days, and 7 days. So there are two things that we were looking for. One is that how quickly can MRC allow us to see evidence of hemorrhage? And what is the best method for that? So we studied a number of animals, over 20 plus animals. The details, as Matthias said, can be all found here. So I want to kind of get to some of the results. One of the things that we looked at is basically hemorrhage in the early hour, 1 hour after reperfusion. And we studied a few animals like this, where we would create the infarct, reperfuse, wait for an hour, and do cardiac MR. And that's what you're seeing on the top. You're seeing an LGE, a T2 star map, and for both a hemorrhagic example and a non-hemorrhagic example. The evidence for hemorrhage in these animals were based off of histology, or gross histology, looking at Mason's trichrome and looking for vascular rupture. And so when you look at cases here, you're looking at 24 hours, 1 hour into reperfusion. The LGE is not just standard LGE, because this is just the coronary vessels, the capillary beds are collapsed, contrast is not getting in there, so the dark region is essentially the infarct zone. If you're familiar with T2 star imaging and you've done a lot of this, you will know that posterior lateral walls are problematic, and the asterisks are indicating artifacts. But when you look at this, even in the case where you have evidence of hemorrhage, now, of course, the histology is done immediately after the animals are euthanized, and then we do histology. You don't see any significant evidence of hemorrhage on the T2 star, but you do see it on the histology. And the non-hemorrhagic infarcts you don't see them on the T2 star. Well, this is an artifact here again, the asterisk. That's another problem with the lung issue with the T2 star. But essentially, you don't see any hemorrhage on the histology, and you don't see it on T2 star either. So when we look at across the animals that we've studied, what we found was that the sensitivity of T2 star, which is what's been validated with the earlier work on 1.5T as the most sensitive method for looking at hemorrhage, was not always visible on T2 star. So the specificity in the cases we did see hemorrhage was very high, but the sensitivity was low, leading to a compromise in accuracy. So this is the first evidence that is actually looking at 1 hour, can we actually see hemorrhage with T2 star? And our evidence, at least in the limited dogs that we've studied, is that we don't see hemorrhage at 1 hour. So then we actually go on and do cardiac MR in other animals that were not euthanized at 1 hour. And here we are looking at cardiac MR across time. So, you have here what you're seeing is sets of images that from animals that were with hemorrhage and without hemorrhage, identified on the basis of T2 star after 24 hours. So this is baseline cases where there is no infarct, and then hyperacute case, typically within about 24 hours, very close to 24 hours. And then we would bring these animals and image them at day 3, day 5, and then week 1. And here what we saw is that by 24 hours, we are actually able to see T2 star evidence of hemorrhage and mild indication of hemorrhage in T1 and T2 images as well. But the main finding from this study is that as time moves on, T2 becomes an opportunity for imaging hemorrhage equally as well as T2 star. So this is exciting because, when T2 star fails, and many of you know it can fail miserably at times, there's really lots of motion and artifacts, off resonance artifacts. So here, this gives us an opportunity to reimage those patients, especially if you're imaging them 5 to 7 days post MI. So this is all dog studies. Okay, so these are some comparisons we did with looking at hemorrhage volume with T2 and T2 star and T1, and looking at transmurality. So you can find these data here. But the key thing here is that when you get to about day 5 and week 1, you don't really see much of a difference in hemorrhage volume, whether you're looking at it with T2 or T2 star. But on the other earlier days, T2 seems to underestimate hemorrhage volume. Okay, so here, this is probably the most important chart here as far as the data is concerned with regard to cardiac MR. So T1, T2 with the ground truth is T2 star. We controlled quite a bit in terms of image analysis, how we identified hemorrhage. And there are about 4 different criteria that we use to really limit ourselves from getting into problems with artifacts. And that's all listed in the paper. You can go and look at that. But essentially what you're seeing here is that if you look at the T2 and T1, you can see that the sensitivity, even the area under the curve, actually increases as time moves forward. By the time you get to day 3, or day 5 is not here, but week 1, you're seeing very high accuracies with T2. Now, that's not to say T1, you cannot see it. You can, but not as well as T2 or T2 star. Okay, so this is very quickly, I'll mention this. We started looking at this and starting to look at which imaging method is actually contributing to either the susceptibility effect associated with hemorrhage or hemorrhage remnants, or edema. And one thing that actually emerged here from this study, for whatever it's worth, based on this analysis, is that what we can say is that the contribution of T1 to the image contrast is heavily affected by edema, whereas in T2 is a little bit more affected on the basis of susceptibility effects. And you can look at that in detail, and we can discuss it as after I go through this. So the other thing I just wanted to show you is our translational study in 50 patients, where we were imaging these patients with T2 and T1 with, again, ST elevation in my patients revascularized with primary PCI. And here we had about 19 patients. We studied about 50 patients, and 19 patients were non-hemorrhagic and 31 were hemorrhagic. And here, again, this is a translational study. So this is only done in one time point. I believe this is done at day 5. Yeah, day 5 to 7. And you can see remarkable evidence of hemorrhage sitting within inside the zone of the infarct zone as identified by LGE. And here, whether we're looking at it on the basis of T2 or T2 star, hemorrhage volume was not different, and also the infarct transmurality also was not different. So that's the major findings from the paper. And this is sort of a central illustration at the end, just summarizing some of our key findings. So I'll stop here, and I'm sure people have questions. I'm happy to take questions at this point.
Yeah, thank you very much for this clear overview. And I cannot highlight enough how strong the clinical relevance is. In stroke imaging, in neurology, it's obvious for everybody that you cannot reperfuse after a few hours because the hemorrhagic transformation then causes a lot of damage. And I would state that this is not much different in the heart. It was just not obvious. And all the few studies that are out there in late reperfusion, they were actually not very good. The data are not good for late reperfusion of acute MI. And this provides the key to have a better understanding, and also to then come hopefully at some point to a kind of a golden window where you can reperfuse. So when you said that T2 star can fail miserably, so what is your high-level assessment of the clinical utility of T2 star weighted imaging or T2 star mapping? Maybe you can also comment on these two in a comparison when it comes to assessing acutely reperfused MI. As we can see, maybe not during the first hour, which is clinically anyways probably not an option, but then starting at 24 hours.
Yeah. Thank you, Matthias. Those are very important questions, and those are some of the things that we've been thinking about as well. So when I say I should maybe curb my comments a little bit, because when it does fail miserably, it does fail miserably. It doesn't mean it fails miserably all the time. So first things first, right? So in our experience, we have about 80% success rate in looking at T2 star images for identifying hemorrhage. Of course, you have to read it carefully with all the caveats that we mentioned in the paper. So about 4 out of 5 times, it's actually good. Now, the other 20% of the time, you can run into trouble. And that's where I think T2 may actually be very helpful. You know, if T2 star has failed, you know, you can still back it up with T2 sort of on a real-time basis. So I think that's an opportunity. But there are opportunities now that are emerging, even you know, that can help with a lot of the off-resonance artifacts and some of these other flow issues that we see with T2 star. First is that we had a paper in MRM. I think it might have been even presented here in the CMR club by Diane. At that time, it was a postdoc in my lab, student and then a postdoc, and where we demonstrate that, you know, where you image the respiratory phase, cardiac phase, these things actually matter for T2 star. So if you're really imaging 3D, you know, that actually helps a little bit with some of the intervoxel defacing artifacts, motion artifacts with, you know, respiration, and also where you're actually imaging in cardiac cycle. Those things actually help, and that allows us to minimize some of the artifacts. It doesn't get rid of it completely. But Randy, who's faculty now at Cedars-Sinai and previously a graduate student of mine, has done really tremendous work and has really published a paper in Radiology Cardiothoracic Imaging where they are able to demonstrate that you can unwind a lot of the artifacts, off-resonance artifacts, particularly on the basis of on susceptibility weighted imaging. And the images actually look remarkable, and they translated it from animal studies into patients. Of course, I'm a co-author on the paper as well, but that beautiful work was done by Randy. And so I think the field is evolving, which I think is really nice to see. Now, of course, you know, when you're looking at reconstruction and all the analysis and all these things have to sort of happen, you know, online. So that's where things are on that front. But yeah.
Okay, thank you. So before I let Rebecca ask a question that she has posted in the chat, I want a quick shout out to one of the other pioneers in T2 star, Graham Wright from Toronto, and also to Reza Nezafat and David Blumke. So Rebecca, you're asking, and I mean, you can also unmute yourself, but you were asking about perfusion in these animals, for example, with microspheres, whether that was a topic for you as well, Ron.
Yeah, so microspheres is not something that we do in these cases of hemorrhagic infarction, because we have other ways and other dyes that we can actually utilize to look at the integrity of the capillary beds. So we don't do that, but microspheres is a bit of a mixed blessing, honestly, because you give microspheres to dogs, they get into all sorts of reactions, and you know, half of them actually have allergic reactions and things like that, and then you're changing the physiology completely and what you're looking at it sometimes. But so we don't use microspheres here.
No, I actually can agree with that. I also found the few times I've worked with them, I found them very cumbersome, and you just interfere too much with the physiology. It's just and they are also finicky in terms of the methodology that is being used. So okay, Rohan, you had a second paper, right?
Yeah, we can try.
maybe we can have a look at that as well, and then continue the discussion, because time is flying.
Yeah, time's flying. This stuff takes time. So let me just.
So maybe you also talk a little bit about the history of the second paper.
Oh yes,
it's related to that.
that history would not be without you and Graham. So, so good people are here. So this is a paper I was really blessed to be able to work with a lot of different people. Let me just so this came out of a sort of a conference or a biennial that we had here at in Indiana, where we had invited some of the thought leaders in ischemia reperfusion injury a couple of years ago. And this is the conversation that took place that led to this paper. But the way this is framed is, if you look at the title, it says reperfused myocardial infarction, the road to CCS classification of acute MI and beyond. And here, what we're talking about is sort of the backstory to the CCS classification. So for those of you who don't know the CCS classification, Dharmakumar and myself, really based on a lot of the work that has been driven by Matthias, Graham, and several other people around the world, really talking about myocardial infarction and how cardiac MR can actually be used to characterize tissue injury. What we really saw as far as the CCS classification was concerned is that when we looked at the tissue injury, as we now know, the injury is different in different people. That's why you have some have hemorrhagic MI, some don't have hemorrhagic MI. But what also emerged over the past 15 years is our ability to look at outcomes in these patients. And then not just us, but globally, there's lots of different groups that have contributed to this. And that led to us to essentially characterize 4 stages of injury. And the first stage, this is going to make a lot of sense for cardiac MR people, because if you've done work in this area, you know how these things are and the type of injuries that you see with T1, T2, T2 SAR, et cetera, and LG included, of course. Here, the CCS classification goes something like this. The first stage essentially is you have an intercellular, maybe even a bit of interstitial edema after reperfusion. So this is what we call the aborted MI. So essentially, there's no evidence of LGE in those infarcts. And the second one is a progressive injury paradigm that we've explained in the CCS classification, which was published in the Canadian Journal of Cardiology last year. And the second stage is necrosis. So that's a phase where you have edema, but now you're starting to see cardiomyocyte necrosis. But the intravascular beds are actually all vascular beds, or the microvascular beds particularly, are all intact. In the third phase, what we see is a loss of integrity of the capillary beds and or even small vessels, and that leads to what we all know as microvascular obstruction, and that we can see very well with early enhancement, some of the work that Matthias did before, and then also late enhancement as persistent microvascular obstruction. And then if you go past that, you get to a point where the capillary beds are not necessarily only just blocked after revascularization of the epicardial artery, but now you're seeing the capillary beds bursting. And that's what we really talked about in the previous paper, essentially intramyocardial hemorrhage. So, and that now leads to the last stage of injury, a significant amount of blood extravasating the red, vascular bed, and extensive injury inside the area at risk. So these are, what we've essentially have coined as CCS stage 1, stage 2, stage 3, stage 4. And this paper essentially talks about how we arrived at that point and all the complexities that the field has seen, and we are essentially summed this up in a way that would make sense and to be able to characterize the outcomes on the basis of tissue injury. And obviously this is a review paper, so it's really driven by a lot of the work that has taken place. And I think cardiac MR has been central to our understanding, or even our ability to characterize infarcts this way. So a lot of people look at this CCS classification and say, well, that's really unique cardiac MR. And I think cardiac MR is going to be the best source. But even when you don't have cardiac MR, there are opportunities to be able to class the different types of the various different stages of injury. So what has happened in cardiac MR, particularly in the setting of reperfused myocardial infarction, is that we are able to, because of the vast number of trials that have been run, looking at outcome data, we have been able to look at outcomes for each one of these stages and be able to say what the major adverse cardiovascular events are in these patients, whether you're following them up for 6 months or a year. And obviously I would not be able to go into all the details that this paper describes, but it does provide a way for you to kind of put everything together, what we're seeing in cardiac MR, particularly because we're all cardiac MR folks here, and be able to understand what is going on, not only from the outcomes, but also looking at fundamental pathophysiology that traces back to looking at non-reperfused infarcts, and then through the 80s into reperfused infarcts, and then the drug-eluting stents, the emergence of that, and then the universal definition of MI, and really the emergence of cardiac MR, really indicating what different types of injuries that are taking place. And I think as a field, I think we've done a tremendous amount of work in terms of being able to help understand what myocardial infarction is and what it actually means and why not all myocardial infarctions can be treated the same. So as you can see, I haven't really moved from the first page, but because there's so much background here, but I urge you to look at this if you're really in this space. And I think it would make a lot of sense when you trace back in history what the field has done.
Thank you very much, Rohan. I mean, as wearing now my clinical cardiology hat, I think this is extremely important. I cannot stress that enough. The problem is that the endothelium, which is usually more resistant to ischemia than the cardiomyocytes, after a few hours, the endothelium gets leaky, the tight junctions open up, and then if you have extravasation of erythrocytes, also known as hemorrhage, this is one of the strongest triggers for inflammation. And then it leads also, and there's also landmark work from Rohan, to more problems because the deposition of hemoglobin leads to iron deposition there. Iron deposition affects electrical stability, and this is maybe a reason for long-term complications in patients with infarcts that turn hemorrhagic. I have one important question, Rohan. The one thing I initially stumbled upon with the stages of the MI was the hemorrhage. Isn't it mostly happening in reperfused or late reperfused MI? So when you say stages, it sounds like every infarct goes through that stage, although stage 4 with a hemorrhage is mostly when you intervene late. So, or am I wrong?
Oh, well, yes and no. So, it's a complex story. So there's a lot going on with hemorrhagic infarction. So late, I mean, you're talking about really the ischemic burden that lasts and how that actually manifests itself as hemorrhage. But there's also this issue of patients who have collaterals and who don't have collaterals, whether the infarcts are proximal, whether they are total versus this and that. So there are a number of different factors that come into play and how hemorrhage evolves. We have a paper in predictive modeling in terms of who is going to develop hemorrhage that hopefully will be coming out. Maybe you guys would have a chance to look at that. But I think so. And then patients with diabetes who have already lost some vascular control and integrity, patients with hypertension. So all these different things play into how hemorrhage actually develops. And late revascularization obviously is one of the worst cases. But if you have collaterals, you can still be okay a little bit. Depend again, late is what is late, right? Is it 12 hours, 24 hours, 3 days after? We don't know. So I agree with you, Matthias, on one front for sure, is that this is a reperfused phenomenon that we're describing. Because you don't get hemorrhage, you don't revascularize. So definitely, but this, this time and age when we're doing all reperfusion, in most of the cases, we're talking about type 1 MIs here that are revascularized, guideline-directed therapy with PCI. That's really what this paper actually covers with PCS.
Yeah. So we have some unfortunately unpublished data, yet unpublished from multi-center trial, where we saw that between 6 and 12 hours after the onset of no-flow ischemia, so not pre-infarct angina, but really with other symptoms, that is the time where you create hemorrhage, and probably they're out salvaging a lot.
Yeah.
So this open artery theory that Eugene Braunwald brought up, that this is now dead. We know that, but there may be even a dark side to that, that if you reperfuse in that window, before the endothelium has time to stabilize. So I think in my patients, if they're stable, I don't, and if they come 8 to 10 hours and they're stable, I will not reperfuse them. I rather wait for a few days. And if they are still then symptomatic, or if they get acutely symptomatic, it's different, then it's maybe. But this is what we have to learn from the MRI studies. And that's why your work, Rohan, is so important. And again, thank you so much for doing that.
Yeah,
so so there's a comment from Graham. Graham, do you want to unmute yourself and ask yourself?
Sure. Great stuff, Rohan. And I know you've been working on this for a long time, and that's why I wanted to get your insights. Particularly, it ties to the latter part of the discussion. At 1 hour, you're seeing MBO, right?
Yeah.
So there's obviously, I guess it's trying to figure, and you're saying that you're seeing extravasation of red blood cells in the histology. I guess the question is, why aren't you seeing the T2 star? Do you think that the MBO is due to the increased interstitial pressure, or is it due to collapse or damage to the vessels itself? Because, I mean, and do you think that the iron is changing over time, and when the iron actually changes to a point where it affects T2 star? I know, lots there, but.
That's there, yeah. So very quickly, I mean, you know this, Graham, I think you can appreciate this quite a bit because, you know, for us to be able to see T2 star, we're going to have to, you know, the red blood cells have to break down and that sort of thing. So, you know, we don't have the data, right, between 1 hour and 24 hours. Well, maybe at 12 hours we can see it. I don't know, but we can't seem to anesthetize the dogs every 12 hours because that's not allowed. So we never did that study, but I think that study needs to be done somehow. I don't know when, who, whatever, but that needs to be done to see if you really want to see it. So I think my understanding is that this looks like a microvascular obstruction. Maybe, you know, even the capillaries are not opening up so much in 1 hour, but it's been, you know, 3 hours of ischemia prior to this. So there's going to be a response there. But I think, you know, you have interstitial edema, post-revascularization, so the capillary beds are shut. Likely there's hemorrhage. Obviously, we see the hemorrhage later, right? After on the basis of histology. So I think this is there's a lot to unpack here, but I think in the 3 hours we are seeing microvascular obstruction. You know, that happens along with hemorrhage. So I think that's all part of it. But I think the whole biophysical transformation of red blood cells within that short window is going to be important in terms of how we are seeing MR signals. And I think that may be one of the reasons, if this is what we're saying, if we're seeing at 24 hours, it might be because of that particular aspect. Yeah.
Cool. Thanks.
Yeah. You're welcome.
You're muted, Matthias.
Always the same. Now, very quickly before we move to Nicole, who will announce the next one, quick question quick answer. Question from Javad Rafi from Montreal. Do you think obstruction of the coronary vasa vasorum may play an important role to the endothelial injury and IMH, so hemorrhage?
Well, those are, you know, those studies, we didn't do the study like that, so we cannot answer that. Obviously, really trying to understand how the vascular bed changes and how, you know, like you mentioned, Matthias, the gap junction proteins, how they actually are impacted, and then the type of pressure that these arteries feel, especially in a point where the vasotone is lost, particularly during ischemia because of, you know, the junctional proteins are affected. There's a lot to study there in terms of pathophysiological, really getting down into the histology level of the vascular bed.
Yeah. Okay, thank you so much. I really enjoyed this, and I hope you can continue, and the field will pick up the importance of this, and more studies will follow. Okay, Nicole, floor is yours to announce the May version, the May edit.
Awesome. Thank you, Matthias. So we are going to be meeting on May 7th, and we are delighted to have Doctors Blumke, Peterson, and Svabo, I hope I'm pronouncing that correctly, to talk about their recent work on updated reference ranges for cardiovascular magnetic resonance. So these are going to be values that came out of the Healthy Hearts Consortium, and then an overall update, looking at multiple different publications. So I'm really excited to hear about reference ranges. I'm like obsessed with reference ranges because I think it's really important to understand, what numbers, we can expect for normal subjects, across age and looking at gender, so that we can accurately understand what the numbers are that we are getting out of our scanners. So I'm very excited to be leading this in a month. So please join us again on May 7th.
Thank you very much, Nicole. Okay, thank you very much, everybody, for joining, especially Rohan for a fantastic presentation and such a good discussion. And I wish everybody all the best, and see you next week or next month. Be well.
Yes.
Bye-bye.
Thank you. Bye-bye.